All. This is Dr. Mobeen Sayed. Welcome to one more show. So the discussion today is very interesting. I want to talk about UK moving away from vaccination, COVID vaccination for all within, and I think from February 12th. So I want to read that notice from them and look at something very interesting in there. Secondly, I want to present in this discussion today the New Zealand data for the myocarditis, pericarditis, increased incidence in younger age after COVID vaccine. And the thirdly, I want to talk about the strokes signal in the US and the behavior of the CDC and FDA, and kind of they're saying like, whatever, or we're working more. So I want to see that data with you as well and see maybe we are simpletons, so we can actually think more clearly than the complex data available to FDA, CDC, and they are not able to make a fast enough decision. I actually think that they might be able to find some help from UK to see how UK is making decisions. So maybe they should kind of tie in with UK as well to say, hey guys, how do you make decisions? That would be a good learning for us as well here in US. So let's start. All three, let's start. I think it's actually a very interesting discussion. So first of all, this is drbeen.com. In the description of this video, there is a link to drbeen.com and look at the price. You will never get this price again. Here is where we are moving to. And it is so sad on my end that we were supposed to cut over to this new business model where we will only offer courses. So, for example, cardiovascular physiology or pathology, and those would have individual prices instead of access to everything for $100 or $97 or $67. And so that code is still being written. They were testing it this week. We were supposed to go out live in the mid of January. We have not. So my hope is next week we will start soft launching it, and some people would see these courses instead of this kind of a page. So if you want to have access to 900 plus lectures on drbeen.com, in addition to the lectures on YouTube, then I would recommend that you take advantage of that now before we cut over. And I pray to my tech team to quickly cut over because we've been waiting for this for some time. Okay, with this, here is the JCVI Advisory Committee from UK. Very interesting. And you would see wisdom in this. So here, published 25 January 2023. And they're saying that in its interim advice to government on coronavirus for 2023, the JCVI on immunization has advised that plans should be made for those at higher risk of severe COVID-19 to be offered a booster vaccination this autumn. So make sure that when you are listening to this talk, see that UK now looks at people in two categories from COVID point of view. Those that are at risk and those that are not at risk of severe disease or death. And then they are responding to them in different ways as well. Very, very wise. It's not bad. So here they're saying that the JCVI also advised that for a smaller group of people, such as those who are older and those who are immunosuppressed, an extra booster vaccine dose in the spring should also be planned for. Advice regarding the spring 2023 COVID-19 program will be provided shortly. And similarly, they have more recommendations here. Why I wanted to put this notice in front of you is that many sites and news reports are simply saying that, hey, no boosters for under 50. But look at the wisdom. They're saying whoever is eligible at risk, the vaccine should be available for them. Then they talk about how majority has already been vaccinated. For example, by the end of summer 2022, the coverage of the 2022 spring booster program was 77.3%. Then they talk about how new vaccine take is reduced. So following the high uptake rates for the initial third booster dose of COVID-19 vaccine in December 2021, further uptake has been low at less than 0.1% per week since April 2022. Then they say similarly, uptake of primary course, that is the primary series vaccination, which has been widely available since 2021, has plateaued in recent months across all age groups. So this is their context. They're not saying just stop this, but they're saying is now make it more targeted to those who need it. Now look at this. As the transition, this is where I need your attention. As the transition continues away from a pandemic emergency response towards pandemic recovery, right? So moving away from pandemic, and now let's start recovering. The JCVI has advised that 2021 booster offer, third dose for persons aged 16 to 49 years who are not in a clinical risk group, should close in alignment with the close of the autumn 2022 booster vaccination campaign. So 16 to 49 booster, if not at risk, then they are recommending that close this campaign for them. Then they say in England, the closure of the autumn booster campaign and the first booster offer will be on 12 February 2023. Closing booster for whom? The ones who are not at risk. We strongly encourage. So now they're saying that, hey, if you haven't gotten it and you are eligible, then we strongly encourage everyone who is currently eligible for a first booster and is yet to come forward to do so before the office closes. And they, at the end of this, they do write that, hey, we keep revising these things. So it is possible that they come in a month later and say, you know what, we shouldn't do this. But this is what they're saying today. However, I think there is even more interesting thing that people are not reporting. That is this paragraph, the next one here. Check this out. They're saying, similarly, the JCVI. So let me back up for a second. So one thing we should agree on, they're saying give the vaccine, administer it, make it available, even have a surge of the vaccine for those who are eligible, who are at risk. Then they're saying for 16 to 49, who are not at risk, there would not be any more booster. We don't recommend further vaccination from 12 Feb. Now the third point, check this one out. Similarly, the JCVI is advising that the primary course of COVID-19 vaccination, primary course, should move over the course of 2023 towards, check this out, towards a more targeted offer during vaccination campaigns to protect those persons at higher risk of severe COVID-19. So general as well, only for those who are at risk. I don't see why people are not actually reporting on this. This is very important. Yes, it is interesting that 16 to 49, no boosters after 12 Feb. But even more interesting is the wisdom they're saying is that, hey, majority of the society has become vaccinated. I'm sure that there would also be serology with infection. And so let's call it protected. That is my word, not there. And then they're saying, move towards a more targeted offer during vaccination campaigns to protect those persons at higher risk of severe COVID-19. We strongly encourage individuals who have not had, this is a very important sentence, we strongly encourage individuals who have not had a primary course to come forward for their primary course before the offer closes. To me, it means what they're saying is, maybe they'll start a new campaign and they'll say, well, here is a new offer. Don't know about that. So barring that, they're saying that, hey, before we stop the primary series for everyone, if you want to have it, come get it. So it's not just the 16 to 49. They're actually recommending just target it to those who need it. And I think that is a very wise decision to say immunocompromised, people with HIV, people with diabetes uncontrolled, people with kidney issues, with cardiac issues, whose risk, people too fragile, people with immune system not functioning, organ transplant patients, where the COVID itself could really be harmful, make it targeted to them. I think that even in those cases, it should not be a mandate, it should be a recommendation. but they are using the word towards a more targeted offer during vaccination campaigns to protect those persons at higher risk of severe COVID-19. Interesting, isn't it? So this is UK. I wish we could just take this verbatim from them and apply it here as well in the US. Now I'm going to go to another different topic. UK is done. What do you think? Is this, Natalia says, why 13 Feb? I think it is 12 Feb because that is their seasonal recommendations. So this is UK. Love it. Wise thing. Now I'm going to switch to the next study. It's a different topic altogether. So change your hats. This is a preprint in Lancet. Preprint, I'm saying it. It's a preprint. This preprint says adverse events following BioNTech, that's Pfizer, BioNTech, mRNA COVID-19 vaccine in Aotearoa, New Zealand. So a region of New Zealand. What they're saying is basically nothing new. This is something that has already been there. We knew these things. I've done these discussions as well. And that is myocarditis. So look at this. This is myocarditis cases reported after mRNA-based COVID-19 vaccinations in the US from December 22. So old news, but still interesting. Here is another COVID-19. This is a comment, COVID-19 mRNA vaccination and myocarditis or pericarditis. This link is present in the description. This person has kind of linked to multiple studies. The absolute risk of myocarditis or pericarditis calculated as the incidence rate within 1 to 7 days of vaccination for men aged 18 to 25 years after a second vaccination dose was 2.17 cases per 100,000 person days for Moderna and 1.71 cases per 100,000 for Pfizer. Again, I'm giving you a context that this is not a new thing, but it is interesting that the verification continues to come in. Do you know, when I have been talking about this, I have always been saying we should acknowledge that this happens so that we can figure out how to help. The sad part is absence of help, absence of planning. Imagine if from the beginning of the vaccination, when we found out that there are thrombocytopenia or there is myocarditis, imagine if we had accepted this idea that, yeah, this happens. Rare or not rare, yes, this happens. Actually, it was very interesting that yesterday's FDA meeting, there was one of the doctors who said, is it really rare? And I thought that was the first time I heard some mainstream discussion where they challenged and said, is it really rare? Because the word rare has become an under the rug replacement. Rare or not, if we accepted it, that this happens, then I think we would have been digging deeper to say, who does it happen to? Why does it happen? Is it a vitamin D issue? Is it magnesium issue? Is it CoQ10 issue? Is it some other allergic autoimmune diseases? That issue? Is it a comorbidities? What is it? But until we accept it, we will not move to the next step. And I think at least here in the US, the response has not been that, hey, we don't accept it, it doesn't happen. The response is, yes, we see it happening. Hey, keep getting vaccine. I think the response has to be, yes, we are seeing it. Let's see, why does it happen? Is it something to do with the vaccine itself? There are some part of the vaccine or the batch, or is it some people's body and their immune system and their response to that? What is it? We should become curious and try to find that out. So back here, New Zealand. New Zealand said in February 2021, New Zealand began its largest ever immunization program with the BioNTech vaccine. We aim to understand the association between 12 adverse events of special interest. So adverse events of special interest are those that must be looked at, and they are more than just normal expected events, for example, allergic reaction or pain or fever or dizziness or sleepiness, right? So these are adverse events. Special interests are beyond those, for example, myocarditis and thrombocytopenic purpura or Bell's palsy or Graves or whatever else, or the spinal cord inflammations. So they said we looked at 12 special interest adverse events and looked at the primary dose of Pfizer BioNTech in age 5 and over, from Feb 2021 to 10 Feb 2022, almost a year, 19 to 12. What did they do? Using National Electric Health Records, the observed rates of adverse events of special interest within 21 days of the vaccination were compared to the expected rates from the background 2014 to 2019. So they said, well, 2014 and 19, these same effects, for example, Bell's palsy or myocarditis or thrombocytopenic purpura or thrombocytopenic bleedings, I forgot the name. So they compared it in the past to see what is expected and what is the increase. And they stratified it by age. And then they calculated it by 100,000. And here is what they found. As of 10 February 2022, 4.7 million first doses and 4.1 million second doses of Pfizer were administered to the eligible New Zealanders aged 5 years and above. The observed rates of some AESIs post-vaccination were not statistically different than the expected rates. And let me give you, before I read the numbers, for me, what is surprising is not the myocarditis. I knew about that. The acute kidney injury in advanced age patients. That is a new thing for me, at least. That kidney injury. So now we have from US stroke signal, which US is saying, no worries, keep going. We're investigating more. They're not saying no worries. I'm saying that. They're saying we're investigating, but keep going. From New Zealand, myocarditis was from all over the world, and now acute kidney injury as well. So now let's look at the data here. The observed rates of most AESIs post-vaccination were not statistically different than the expected rates. So most cases, no issue with vaccine. The incidence risk ratio, 95% of myopericarditis following the first dose was 2.6. So incidence risk ratio is that you take incidence, that is presence of the disease over a time in a population. If you take that from 2014, was that the window? 2014 to 2019. And if you take now and you divide them, that would give you what extra is present. So that was 2.6 with a risk difference of 1.6 per 100,000 persons vaccinated. So 1.6, and this was statistically significant. Range is 1.1 to 2.1 per 100,000 extra, and was 4.1. So you might say, all right, fine, for 100,000 persons vaccinated, 1.6 people more, 1.6 more cases. Fine, doesn't look very big. But keep staying here for a second. Was 4.1, and the range is 3.7 to 4.5, with a risk difference of 3.2, 2.6 to 3.9 per 100,000 persons vaccinated following the second dose. So after the second dose, it was 4 per 100,000, for example, more. But that is still, you might say, well, 4 more 100,000. Check this one out. 25.8%. Oh, sorry, not percent. 25.8 in the 5 to 19 years age group following the second dose of the vaccine, was with an estimated 5 additional myopericarditis cases per 100,000 persons vaccinated. That is a large IRR. And so it does behoove us that we think more clearly, and I'm talking about CDC and FDA's, that in the younger age, the need for vaccine is not that high unless the child is at risk because of comorbidities. And then the vaccines and the boosters, there is a clear association for the risk. And here, this is a statistically significant association, meaning it's not a fluke, it is proven, and more in children. An increased incidence, now I'm switching gears from epicarditis and myocarditis, pericarditis and myocarditis, an increased incidence of acute kidney injury was observed following the first and second dose, and first 1.6 and second 1.7 of BioNTech. Interpretation, although rare, see this word, although rare, I have become so uncomfortable with the word rare, not because these are rare or not, but the usage of rare has become a way to mask the response needed by simply saying it's a rare thing. I can understand these can be rare, but what are we doing for them? So, although rare, it's statistically significant association between BioNTech vaccination and myopericarditis and acute kidney injury was observed. While the association between BioNTech and myopericarditis has been confirmed internationally, further research is required to understand the association of AKI. They're saying, well, this is the AKI is something that is a new thing, at least, or less recognized thing. We need more investigation in there. BioNTech was not found to be associated with most of the other AESIs investigated, providing reassurance around the safety of the vaccine. And this also tells me, and please, you would see this same pattern with CDC and FDA's stroke discussion. If there is no other issue, but then there is one issue, that tells you that your measuring system is correctly measuring. So you have to respond to the issue that is apparent. You would see that with the CDC and FDA as well. They would say that other issues are not seen. With Moderna, we're not seeing this. Then we're seeing this with the strokes. Even they say, well, we are still investigating. I think that all data pointers, if these signals are honing in onto one area and are clearing other areas, then we must respond to that area where there is signal. So here, this study not only shows myopericarditis, but acute kidney injury. So this is interesting. Again, a preprint. We'll see if there is more data that comes in. The context with this, as I had said before, this is January 25, 2022 myocarditis cases. And I'm sure that I have done a lot of discussions about myocarditis as well. This is another risk of myocarditis and pericarditis after the COVID-19 mRNA vaccinations in the US, a cohort study in claims database. So here as well, if you see the pooled IRR, incidence risk ratio, in the head-to-head comparison of the two mRNA vaccine was 1.43 with an excess risk of 27.8 per million doses in mRNA 1273 recipient compared with BioNTech. An increased risk of myocarditis or pericarditis was observed after COVID-19 mRNA vaccination and was highest in men aged 18 to 25 years after second dose of the vaccine. So what is the evolution of this? From this study, this preprint, the evolution is that they are seeing 5 to 19 years to be more at risk, or finding more incidents there. So this is another interesting one. If you like, I can do a more deeper dive to work with various age stratifications and discuss it. But I wanted us to at least see what they're saying and also notice the acute kidney injury signal that they are reporting. Okay, moving on. So what do you think will be our US's response. Here is CDC. This is updated September 27, 2022. Myocarditis and pericarditis after mRNA vaccinations, inflammation of the heart. So they're saying myocarditis and pericarditis have rarely been reported. When reported, the cases have especially been in adolescent and young adult males. More often after the second dose, usually within a week of the vaccination. Here, the New Zealand showed within 21 days. Most patients with myocarditis or pericarditis who received care respond well to medicine. Patients can usually return to their normal daily activities. Those who have been diagnosed with myocarditis should consult with their cardiologist. And then, should I keep getting my vaccination to my child? Yes. This is CDC. If we had gone back to the way UK looks at things, they would have said, hey, reduce the risk by only offering it to those who are eligible, who are at risk. Then CDC again, clinical considerations, myocarditis and pericarditis after receipt of mRNA COVID-19 vaccine among adolescent and young adults. So once again, these rare cases of myocarditis or pericarditis have occurred most frequently in adolescent and young adults, males age 16 years and older. Again, go back to the New Zealand, they are saying 5 to 19. Within 7 days, they said within 21 days. After receiving a second dose, they said both first dose and second dose. So after this study, CDC continues to recommend COVID-19 vaccination for everyone 6 months of age and older. Okay, third topic for today. This one is something that makes me frustrated, and that may be because I am, as I said in the beginning of the talk, maybe I'm more simpleton. Maybe I have a more simpler way of looking at things compared to more scientific and complex things that folks that you saw yesterday in the advisory committee meeting, they were doing. So I will concede that first. This is a link present in the description of this video. This is the link to the video that if you would like to watch, we did a little bit, but we got really annoyed and bored and we stopped. And then at the end of this page, there is a list of all the documents. And I am going to be showing you one of the documents that they presented as well. Here is that document. I'll give you a basic summary of it first. There are many signaling systems, so there are many alerting systems. There is VAERS and there is VSD, and there are other healthcare systems which are reporting data for vaccine-related safety concerns. Now, a signal, they have a definition of a signal that, for example, the data becomes statistically significantly higher than expected data or events, counts, numbers, and that becomes a signal over time and so on. So they have given the definition of what their signal was. I'll also tell you their basic response first, and then we look into the data. So you have this context of what did they actually do about it. So their response yesterday was, keep going, keep going, keep going. We are investigating. We continue to recommend you keep moving forward. This is the message. You can hear it from their video as well. And I am putting that message in front of you before we look at the data. Now the data. CDC's definition of ischemic stroke and FDA's definition of ischemic stroke was different. CDC's definition included transient ischemic attacks or TIAs. And the TIA generally, I'm not speaking the definition of it, generally transient ischemic attack is an attack where there is ischemia or loss of oxygen supply to the tissues that happens to brain tissue for some time, and then it restores within mostly 24 hours. So that's a transient ischemic attack. It recovers, it goes away. This TIA is included in the definition of CDC, but not included in the definition of FDA. So what happened was when CDC measured the signal, they saw the signal statistically significantly, meaning the numbers were statistically significant. They saw a clear signal with statistical significance. FDA had not had the TIA included in their definition, so they saw nothing. So here we simple folks can probably sit down together and say, okay, this means there is something to do with the TIA. So instead of saying that, hey, we may have something to do with TIAs, we need to do more research there, they simply said, we didn't see all this data everywhere. Well, your definitions are different. You are never going to align until you want to say that stroke plus TIA equals stroke for FDA, and they both numbers have to match. They would never match unless TIAs disappear and just the ischemic strokes are present. Do you see the delicacy here of the definition? They should have at least yesterday, if not accomplishing anything else, they should have said, from now on, we will agree on the definition to synchronize the definition. At least that much, so they can measure it correctly. So I'm going to present to you what CDC showed. This includes TIAs. So if I go down here, and the links are in the description, you can read it. Here is the, let me actually go here. This is what they said their scheme was. What they did was their signaling system looked at, here is the vaccine. I hope you can see my mouse cursor on the first vaccine in the top left. Here's the vaccine. And then within 21 days, they looked at any risk, any event. Then they compared that to 22 days to 42 days, and they saw, in comparison to these two, what is the outcome. I actually think it is an incorrect way of doing it, but that is what they did. I'll tell you why it is an incorrect way. It is expected for antibodies and inflammatory response to peak soon after the vaccination and then wane afterwards. So if there is any risk of TIAs or strokes or myocarditis or thrombotic thrombocytopenia, somehow I was missing this term today, that would occur within the first few weeks. It may be 2 or 3 weeks, but then as the time continues to go past, the risk will continue to reduce. However, they used the 22 to 42 as non-risk time to compare that to the risk time. So in that way, it is okay. This is their definition. So if you see here, in this definition, they are called ICD-10 codes to find incident cases, other transient cerebral ischemia attacks, transient cerebral ischemic attacks, cerebral infarction, stroke, ischemia. So they used TIAs as well, right? FDA did not use the TIA. And here are further definitions, so you can see that. I want to show you this data. This data for me, again, I'll keep conceding that fine, I am not as great a scientist as they are. Although looking at them slouching on their chairs and talking yesterday just took away all my trust in them. And just continuing to say, we're investigating more. We need more data. It's just very difficult. So here, if you look at this screen, bivalent RCA, concurrent comparator analysis of ischemic strokes during 1 to 21 day risk interval versus 22 to 42 days. And if you see here, 65 plus, Pfizer, this is their own highlighting. So it's not that they do not know or hiding anything. Pfizer, look at the 2 line, Moderna below. So this actually tells you if Moderna didn't have it and Pfizer did have it, then there may be something to do with Pfizer. They kept saying that, well, we don't know. Maybe there was something else. Maybe all the people who got Pfizer had something other than just the Pfizer. Risk events were 130. Comp events were 92. Look at the Pfizer. Risk event 57, comp 49. Adjusted risk ratio 1.47. So 47% more. 1.47. The question in your mind will be now, is it statistically significant or is it just a fluke? And that is answered next. 95% confidence interval, 1.11 to 1.95. So it does not cross unity. It is above unity. So all good. That means 11% to almost double the risk. And then you would say, well, how about the p-value? And the p-value is 0.005, which is also statistically significant. That means this signal has statistical significance. This data, when they looked at it, their answer should have been, we see that there is a signal. They actually did some analysis of 24 cases as well out of these 130. There is a signal. In abundance of caution, we are suggesting that 65 plus continue if they are eligible, if they need it, if they're recommended, take Moderna. We'll come back in a few weeks and do some more diligence and then update you. But that didn't happen. The simplest answer from them was keep going. We are investigating. So this is a statistical signal. Now, if you said, did FDA found the same signal? FDA found nothing. Why? Because the definition did not include TIA. So I would like you to hear this dialogue that occurred yesterday. So I'm going to stop sharing and reshare with the audio sharing so you can hear what they're saying. So give me 1 second. So I'm going to share again. And now I'll share with my system audio shared as well so you can hear. So I'll give you the context. This is FDA. In FDA's definition, FDA said we did not find any signal. Well, because your definition was different. So here, this, I believe she's Dr. Chatterjee. She asked this question. So I'm going to go back and hear her question.
CDC definition included transient ischemic attacks as part of CDC definition presentation. So thank you very much for your time and attention.
Thank you for a very good presentation. We have about 10 minutes for questions. So Dr. Chatterjee.
Yes, thank you very much, Dr. Perlman. Dr. Boshi, thank you for your presentation. I have two questions for you. The first one is with regard to the definition of ischemic versus hemorrhagic stroke, because it seemed like for the VSD analysis, they used ischemic stroke, and for the FDA's analysis, non-hemorrhagic stroke was used. Is there a material difference between those two definitions?
The key difference between the two is that the CDC definition included transient ischemic attacks as part of their definition of ischemic stroke, whereas we did not include TIA as part of our definition of non-hemorrhagic stroke.
Thank you. The second question is with regard to this study.
So now I'm going to take out their audio, but I hope you heard from this audio that Dr. Chatterjee said that, hey, are you using a different definition? And FDA said, yes. I think that is Dr. Froshi from FDA. He said that, yes, we are using a definition which does not include TIA, and CDC is using a definition which includes TIA. So their data do not match. And they are actually using that as to say, well, CDC found a signal, we didn't find a signal. The data doesn't match. They're not looking at the same data. So back to the CDC. So here they're looking at this data, and then they're saying, this was actually a surprise to me yesterday. I could say shock. I don't want to be more dramatic here because the data should speak for itself instead of me. They actually saw this signal in October of last year. So if you see here in this graph, the blue line is 1 to 21 day risk interval. So event, whatever it was, event, in this case strokes, within 21 days of the vaccine. The orange one is 22 to 42 days comparator event duration. And then the rate ratio, to create their ratio with each other to say if there is a signal. And so if you see here, the gray line is the rate ratio. And in October, they had the signal that went up to 3.95 times. Then it went up to 4.38 times. Then it went down to 1.51, then went up again to 1.92, 1.82. Then it came down to 1.47 now. So yesterday they kept insisting that, well, the signal is now coming down. Well, you saw that it went down to 1.51, 2.25, then went up again to 1.92. Why are you taking this risk? Why, are you sure that this 1.47 will once again not go up to 2? And how difficult will it be to say, fine, don't take Pfizer for a few days. Go take Moderna for 65 plus. How difficult is that? And how wise would that look like? How much trust will we develop? Instead of saying, well, all other system says no issue, so there may be a confounding factor here. So what they're saying is, within all of this time, starting from October till now, those who took Pfizer had some other confounding factor that was not present with Moderna. And we are researching that factor. And they keep saying that it is very difficult to figure out what is the right thing, what is the... And I can understand scientifically, it is difficult to figure out what may be causing it. But here you have a very correct temporal association. At least rule out the main thing, the vaccine, the Pfizer vaccine. At least stop there. Then look at the data. And if you insist to keep going with this so that you have more data produced, that is just unethical. So here, ischemic stroke after Pfizer bivalent booster, age 65 years, counts an adjusted rate ratio. So this is once again more. You can see rate ratio is 1.47. This is another graph where they show the clustering of the event. So within 21 days, the clustering of strokes was high. So then they go and do some analysis. So out of 130, they went deeper for 24. And they said none had any history of stroke or TIA. Median age was 77.5. Symptom onset date rarely shifted from electronic date. 23% with known history of SARS-CoV-2 infection, only one within last 6 months. So that was not really something to pin the problem on. 0 with mention of recent exposure to SARS-CoV-2 in chart notes. So again, they know this data. They have written, I'm reading their data. 64% had flu vaccine co-administered on the same day. 13 high-dose flu vaccine and 1 unadjuvanted flu vaccine. So if I now go here, so we saw this yesterday, 59% discharged, 18% with home health, 9% nursing facility, they became so much damaged, 14% died. And if you see here, I want to share this one as well. Where is the flu vaccine? This one. This is an additional interesting data point. What that data point is that, so of course now let's say they're saying, hey, keep going, keep getting the vaccine while we're trying to figure what this is. And so now they're looking at what are the other factors. So here they found, once again with statistical significance, they found that bivalent Pfizer vaccine, it didn't happen with monovalent. Bivalent Pfizer vaccine, it didn't happen with Moderna either. So see, it can become more focused. Bivalent vaccine, same day, high dose adjuvanted flu vaccine. 40 cases, and in 22 to 42 days, 20 cases, so double the ratio. So if you said, okay, fine, this may be a fluke, how about if the flu vaccine was standard dose? So 3 cases with standard dose flu mixed with or given together the same day with COVID, Pfizer, 3 cases. And in 22 to 42 days, 4 cases, 0.7%, so lesser risk. So that once again focuses you back on the other line above. And again, this is their data. If they look at this data, ideally, I thought at least CDC would say, we think we have data here which is statistically significant, maybe small, but we should take precautions. They didn't do that. Bivalent Pfizer without any same-day flu vaccine, these were 60. So remember, there were 103 here that they're looking at. 60 were bivalent Pfizer without any same-day flu vaccine. 60 cases. In next 22 to 42, 58 cases, almost 1-to-1. So it almost brings you to this that, well, it does look like bivalent Pfizer vaccine with high-dose flu vaccine together on the same day is the culprit. They actually showed it, and then they said there may be more confounding factors. We're still working on it. So their key notes: CDC continues to recommend that everyone eligible for COVID-19 vaccine booster or flu vaccine get vaccinated. CDC and FDA are engaged in epidemiologic analysis regarding co-administration of the boosters. I would actually, if you really want to get the impact of what they were doing, I would like you to hear this, where Shima Bukuru and this Faroshi doctor, they would just keep coming back and one after the other and keep saying, keep getting the vaccine, keep getting the vaccine. I felt that they were more concerned with the keep getting the vaccine message compared to here is a risk and we need to do something about it. This is where I contrast it with UK. UK said, hey man, majority of the people have the vaccination now. The uptake is reduced. Why not we now make it more focused? Let's just close it for where it is not necessary and move on. Wise decision, moved on, and there they are. Anyways, sorry for such a long talk. Please do me a favor, like, subscribe, and share. And also, if you would like to take advantage of Drbeen Access, just a few days, the link is in the description at this price. And then once we have our courses pages up, then even cardiovascular physiology is $100 or so. So it would change. And please tell me, what do you think? And once again, I have been requesting this for last few days, that when you have this discourse over here, imagine you found an error in my talk, point out that here is an error and add and extend the discussion. Correct the discussion, add to the discussion, or agree with the discussion. However, calling names to each other or calling names to me, it doesn't matter too much to me. But if you start with Dr. Bean is such, then I actually don't read the rest. I have no interest in reading insults. So if you really have a point of view, then add that to the discussion. But if you just want to insult and move on, that's fine. That's up to you. I usually block such folks or remove them. So with this, please like, subscribe, and share. In the description of this video, there are some links if you would like to support this work. If you like this work is very different from other presenters. There are some that are just pro-vaccine and they would always just say vaccine good. And then there are some that are just anti-vaccine and they say vaccine bad. Here, I try to make sure that we look at the whole thing in a more balanced view, and you are able to look at data to make your decision. So with this, there are links in the description. You can buy me a coffee. You can use PayPal. You can become Substack member. You can become a patron, and so on. Thank you very much. I'll see you on Monday. Bye-bye.